Virtual Medical TB Consilium, the initiative of WHO Regional Office for Europe. I am Elmira Gurbanova, coordinator of the Virtual Medical Consilium. And let me remind you that the webinar is held in English with translation into Russian. You can choose the language that is convenient for you to listen and to view the presentations. Moreover, all presentations can already be downloaded from the link broadcasted in the chat. We will also post a video recording of this webinar later in the same folder. And today, we will discuss the sensitive topic of TB-related disability and post-TB lung disease. We will have 3 great speakers who will make presentations, and during the presentations, I invite you to ask questions in the chat. The presentations will be followed by a question and answer session where our panelists will answer to your questions posted in the chat. So to start the webinar, I'm pleased to give the floor to Mr. Alexander Korotic from WHO Regional Office for Europe. Alex, the floor is yours.
Thank you so much, Elmira. Dear colleagues, greetings to everyone. First of all, on behalf of Dr. Yedilbayev, our regional TB advisor, who could not join us today, but he sends his greetings. You know, today, despite the summer period, we are happy to see such a high attendance and a large number of participants joining our 22nd webinar of the Virtual Medical Consilium, which will be dedicated to post-lung TB disease. Post-TB lung disease, as we all know, TB is one of the deadliest infectious killers in the world. Therefore, the major resources at national and global levels are streamlined towards managing and curing patients with TB. However, even in cured patients, TB can often result in either temporary or permanent disability arising from the disease process itself or side effects related to TB treatment. So our today's webinar aims to provide an overview of TB-related disability and talk about the key interventions and clinical standards for management of post-lung TB disease. We also have an opportunity to hear about the experience of Latvia in implementation of pulmonary rehabilitation after TB cure. So we are very happy to have such a renowned speakers today presenting at our webinar. And without further delay, I am passing the word back to Elmira to introduce our first speaker. Thank you so much.
Thank you so much, Alex. And I'm really glad to introduce our first speaker, Dr. Ernesto Jaramillo from WHO Headquarters Global TB Program, who will provide us with an overview on TB-related disability. Please, Dr. Jaramillo, the floor is yours.
Thank you. Hello, everybody. Very much pleased to be with you all, and I'm very happy to see some friends on the screen. Some of you might thought I have disappeared, but I have not. I'm just working in other fronts. MDR TB remains part of the areas that I'm covering, but through other policy elements, and this is one of them. I mean, MDR TB has been a source of refreshing air to the whole response to TB. And any clinician, including me, who has treated people with multidrug-resistant TB is very familiar with the reality that declaring a person cured doesn't mean that all health problems are solved. Actually, is the beginning or the continuation of a new journey in which major health issues are presented, plus all the social and economic consequences. So over the last 3 years here in the department, we have in Geneva, we have accelerated the process of moving forward the policy agenda to address what we are calling the TB-associated disability, which is a bigger package of things. And what I'm going to do over the next 10, 12 minutes, Elmira, you confirm to me the time available, is to present to you the work that is being done, is ongoing, and the policy perspective to secure that we can really move forward with ensuring a comprehensive, holistic approach to the healthcare of people affected by TB, moving beyond this notion that it's all about eliminating the bacilli from the lungs. I'm going to move to the first slide. Then, please confirm then if those who are following on the Russian version are now on this slide that is
Yes, all good.
presenting a publication of a systematic review that some colleagues of WHO undertook 3 years ago, which was basically to go and do a systematic review of the evidence on TB-associated disability. And what we found was not surprising, but it was great in the sense that set the basis for us to make the case. I mean, it's not enough to have a collection of anecdotes of clinicians who we have seen so many things, but until this can be presented as really an issue with hard data, then it's more difficult to move. And what this systematic review on the burden of TB-associated disability show is that there are 3 major conditions that are driving the impairment and disability during and post-TB disease. Mental health conditions, non-TB, pulmonary conditions, and musculoskeletal neurological disorder, particularly the sequelae of meningitis and spinal TB that particularly in high TB burden countries has serious consequences. So this is a very important work. This systematic review is saying this is not a speculation. This is an issue. The people are cured of tuberculosis, but the burden left in the health system because of all this impairment and disability is huge. Next slide. You will see during my presentation that I'm highlighting and emphasizing that these problems are not exclusively limited to the post-TB treatment. No. This is during and post-TB. This has major implications. It's not an issue of semantics. It's not an issue of perspective. First is the reality. All the problems that in the literature you are reading and seeing covered under post-TB are also problems that are occurring during the course of treatment. And hence, we cannot ignore that fact. And secondly, the other fundamental implication is that the people who can take care of the post-TB are not necessarily, in the vast majority of countries, the national TB program. So we cannot leave this problem orphan. It's precisely the national TB program, the ones who are in the best position to make early detection, prevention, first of all, prevention, early detection and proper management of all these associated disabilities during the course of treatment, and set the grounds for the primary healthcare services to do the follow-up during the post-TB phase. Having said that, let me move to then highlight some quick facts, and there is no time to go into the literature that confirms that morbidity and mortality are major issues caused by these TB-associated disabilities. They are adding cost as well to the household economy during and post-TB treatment, are affecting the quality of life, and something that is a compelling fact. Treatment outcomes of tuberculosis are affected by these comorbidities, by this impairment. Hence, there is here a compelling argument to persuade the authorities, listen, you want to really not to waste your investments in treating people with TB, then please do invest as well in addressing all these associated impairments and disabilities, because then you will enhance the impact of the investment you are making on diagnosis and treatment of tuberculosis. The other fact from the systematic review is that global burden is massive. Imagine a factory, which is our TB program, which are releasing to the community, to the society, every year, millions who are suffering of these TB-associated disabilities. That requires follow-up. There is also, and this is even more sad and worrisome, clear evidence now collected and produced in the last 5 years that the life expectancy of people is 4 to 6 years shorter just because having had tuberculosis. I mean, it's horrendous. I mean, for mental health condition is even more. something like 20 years, but just for the fact of having had tuberculosis, your life expectancy is shorter. There are not yet concrete, convincing evidence that can indicate what is the cause of the shorter life expectancy, but we can speculate with some plausible hypotheses that the associated disabilities are likely to be behind this excess mortality. This is another powerful reason why this TB-associated disability cannot be an option, but a must in the response to tuberculosis. Last but not least is the fact that there is evidence on the feasibility of it and effectiveness of interventions to manage these conditions from the clinical perspective. But under programmatic conditions, we are having a major gap, which is a point that GB and colleagues considered in the publication of 3 years ago when they introduced the clinical standards for managing at least the pulmonary comorbidities. Next slide. I would like to remind you that WHO, or to make clear, because probably many of you didn't know, WHO has kept this in the radar since 2015 very carefully. There is a TB sequel project based in the University of Munich and with other university in Germany that is a consortium of something like 5 institutions, mostly in sub-Saharan Africa, that has since been conducting some longitudinal studies on TB-associated disability due to pulmonary conditions. And now they are broadening the scope. WHO has been supporting this project since 2015. They have got now an additional grant last year for extending the scope of the project. This is a fascinating project that is going to produce unique data. Is a follow-up of something like 10 years of people who are affected by tuberculosis. And we are working very closely with them to get the evidence that can enable WHO to produce guidelines within the near future. Secondly, an important point, and for the sake of making the case to the decision makers at country level, is to remind everybody that the NTB strategy is calling for integrated patient-centered care. That means that we cannot limit only to treat tuberculosis in isolation of the other needs, values, and expectations of the people affected by tuberculosis. After intense work from our side, we managed to get in the Global Fund strategy narrative in 2022, the inclusion of TB-associated disability within the scope of things that Global Fund is happy to fund. Then came the framework of comorbidities that was launched last year, and that it's outlining very clearly how all these TB comorbidities should be part of the response. Traditionally, it has been a very strong focus on HIV, but this is not the only thing that matters. Of course, there are countries in which the HIV epidemic is a major driver of the TB epidemic, but even in those countries, there are other comorbidities that are heavily contributing to give direction and shaping up the epidemic of TB. We are now in the clearance process internally in WHO of producing a document of 4 or 5 pages that is outlining the policy on TB-associated disabilities, a policy brief, and later this summer we will be launching this. Probably is a matter of 2-3 weeks. Of the 3 major disabilities I mentioned, one of them is mental health. And also later in the summer is now clear, approved, and developed. There will be a guidance on TB and mental health collaboration to basically nothing different of what happened with HIV and TB collaboration. Every person with TB has to be assessed, tested for the 4 major mental health disorders: depression, anxiety, psychosis, and substance use at the time of diagnosis, receive support during the course of treatment, and be evaluated again, particularly if the person has not been defined to have a mental health disorder, to be evaluated at the end of TB treatment in order to identify who are those who may need follow-up and then ensure proper referral. We conducted in order to prepare, setting the ground to prepare guidelines on the management of the impairment and TB-associated disabilities during the course of treatment and post-TB treatment, a scoping of the literature with two major researchers well experienced in the field, and the outcome of that scoping review confirmed that there is not direct evidence that enable us to produce guidelines. Yes, you go to any clinician and you know how to treat COPD, you know how to treat bronchiectasis and so on and so forth. But when it comes to evidence about how to manage this in people with tuberculosis, or in the context of a program of tuberculosis, the evidence is insufficient for WHO to produce guidelines. Hence, what we are moving forward is to take stock of the reality. The absence of evidence for programmatic management should not deter to provide advice and move forward in producing the evidence using what we know is being done in clinical management of these pulmonary comorbidities. When you have tuberculosis and you see a clinician, that clinician is going to say, oh, sorry, WHO is not yet recommending anything, hence I cannot provide you any support. Of course not. That is not what happened in the field. What we need is to move to ensure that we build evidence on the programmatic management of this condition in the context of the TB services. And hence, toward the end of the year, we will then develop an operational resource protocol and a guidance, nothing different to what happened with the shorter regimens for MDR TB, in which the evidence were piling up, but we need to answer still some questions, for example, on safety of the regimen, plus the feasibility under operational conditions. So this is the direction we are moving, and this is a field that many of you, when you go to the literature, you see how is the evidence piling up. And this is great because it has been very difficult over the last 10, 15 years to make the case, because from WHO perspective, we cannot move forward towards policy making just with a collection of anecdotes, or because someone is crying, oh, I'm suffering of this and that. Where is the evidence? And that evidence is now enabling us to move forward. Next slide. The policy brief is going to cover then these 6 areas. It's just making policy statements to make the case. This is the position of WHO, nothing different of what I have mentioned before, but highlighting particularly the importance of stigma and discrimination as one of the elements that we need to consider, particularly in the context of some comorbidities and in the context of mental health. The need to ensure collaboration with other sectors. Many of the people affected by these TB-associated disabilities during and post-TB require the support of the social protection services. Hence, we need to secure that a collaboration in the context of MAF and in the context of whatever social protection system exists. But also not to forget that we need to maintain the interest in building evidence through research, because without evidence it's very difficult to produce the guidelines that can help us. Do you want me to get closer to the end, Alexander?
Ernesto, sorry, it was some unintentional from the part of our participants.
Sorry. Okay, thank you. So I don't want to, I don't think it's necessary to go into the fundamentals of the framework for collaboration for management of comorbidities, but key principles are there and are related to what we have to do in the management of these TB-related associated disabilities and comorbidities, particularly in the context of mental health and pulmonary comorbidities. Next slide. Here is from that framework a heavy slide, but you can go in detail through the PowerPoint you will receive from us. But the response when we call to the programmatic management is to ensure to have capacity in the health system to address the problems that people with tuberculosis are suffering during the course of treatment and post-TB. In this context, then, we need to realize something. Donors that are funding their response to TB tend to focus only on TB. Hence, we need to be smart and not to be naive of pretending that those donors are going to fund the care of people who are cured of TB. And that is one of the reasons why I would like to emphasize that the focus on post-TB disease could be counterproductive. We are here talking about the problems affecting people with TB, and by building capacity in the health system to address those problems, we leave the health system in better position to address those problems once the person is discharged of the TB program, and then the primary healthcare system has to take care and follow up on this. We need to accept, not to accept, but to understand that there is a chronic underfunding in the response to TB. And if anything, the needs for funding the response keep growing. And here, with the emergence of TB-associated disability as a part of the response, then there is additional funding needs. Imagine that, not imagine, and realize that pretty soon we are going to have a recommendation that basically is going to say every person with TB at the time of diagnosis and during the first days after enrollment needs to receive a proper assessment for mental health condition, but also a baseline spirometry and a proper assessment to identify which are the other pulmonary comorbidities affecting the patient. That implies money, resources, building human resources, building capacity, ensuring that there are the proper commodities to undertake this, to deliver these services. So these are the important political, but also policy context. TB programs are the ones who are in the best position to ensure that we can make prevention by early detection, of course, and effective treatment, and quick enrollment and treatment of people diagnosed with tuberculosis or MDR TB, but also to make early detection whenever there is one of these comorbidities, and ensure that the response to TB is not focused exclusively on the people sick with tuberculosis or just on the post-TB disease phase. Global Fund has received those applicants to the Global Fund and those who are willing to get the opportunity to get supported to undertake this initiative. This basic guidance, these are the general objectives that you may want to include, that countries may want to include in concept note to the Global Fund, and ensure that this is done preferably under operational resource conditions in order to build the evidence that we are all in need. This is an acknowledgement to the colleagues and partners who have been contributing to shaping up this policy approach, both in its policy and political perspective, but also in the building of the clinical elements, particularly with the colleagues based in Stellenbosch, South Africa, but also at the University of Munich in the TB Sequel project. Thank you very much. I'm happy to take comments, feedback, questions.
Thank you so much, Ernesto, for that excellent overview and very useful information. I'm sure that our participants will consider this operational research in their future Global Fund applications. Thank you so much once again. And now I'm honored to introduce Professor GB Migliori from the Blucher Collaborative Center for TB and Lung Disease in Italy. He will talk about the overview and clinical standards on management of post-TB lung disease. And meanwhile, dear participants, please feel free to write your questions to our panelists in the chat. Dr. Migliori, the floor is yours. Your microphone is muted. Unmute your microphone, please.
Okay, fine. Thank
Great.
you so much. So can you see the screen?
Yes.
Very good. Right. So thank you very much for inviting me. I'm very, very honored. And I am now in a very peculiar environment because there are here near Sondalo, many of you have been there, right? The World Championship of Rafting, and I was asked to coordinate medical service here. So I'm in a tent, and you will see some movement, but we have the essentials to be able to go on with that. Right. So I was asked by making an overview of post-TB lung disease and then describing in the next presentation briefly the standards, the union standards for TB care, which were published last year in the journal, the International Journal of Tuberculosis and Lung Diseases. How much time do I have? Some 45 minutes, something like that, please, correct?
Exactly, yeah.
Very good, right? First of all, thank you very much, Ernesto, for this. And I think it's important to go on speaking and pushing, and I will comment then later the importance of starting including these activities when doing program reviews and supporting development of national strategic plans and things like that. So I move to next slide, which is not coming now. Why it's not coming? Voila. I have no conflict of interest. Next. Fine. So the fundamental question here is whether we have finished our work when the patient is cured. And the obvious answer from what we have heard from Ernesto is no. So the story is I will follow an historical perspective, starting from the first review, basically, which was our review on the Journal Brasileiro de Pneumologia in 2016. Then I will briefly describe the contribution of the Stellenbosch Symposium. I will cite a couple of important findings from the fundamental Lancet Global Health paper, which allowed to measure the QoLs, comparing those during disease and those for post-TB disease. And then I will also briefly describe a clinical document which has been recently published by the International Journal of Tuberculosis and Lung Disease. And I will also make a little bit of comments on the importance of considering cross-sectionally also the post-COVID stuff, which have a lot of elements in common with the post-TB disease. Next slide. So, have we finished our work? Next. No. So in the classical description of what we expect to be able to do, then we can do early diagnosis, adequate treatment, having a proper infection control in place. We have a prevention side with TPT and vaccination, BCG now, hopefully soon a new vaccine. But there is this issue of the post-TB disease, which is growing. And we see from here that, let's say, from the very beginning, the number of publications on this are increasing, going up. And slowly, Ernesto will have more, let's say, evidence to put in the, to cook, let's say, hopefully, policy interventions. Now, the story of the first review. So my own contribution as I'm chairing the Global Tuberculosis Network was to start making noise about this. And I was among the groups and the people who started to do that. And we started with this review in 2016, which was divided into 4 chapters. The first was the post-treatment sequelae. The second was the evidence on the destroyed lung, which is the extreme level of the sequelae. The specific chapter on functional evaluation of the sequelae, both for drug-susceptible and drug-resistant TB, and an issue which has not been considered much in all previous documents, which is pulmonary rehabilitation, which is the essential focus that I have in my background, which includes 3 main areas, which are physiotherapy, oxygen, and ventilation. Next. And in the, let's say, 2016 review, we started from a story of a patient, which I think is a good way to start that discussion. So an old susceptible, young susceptible patients, which was considered cured, continued to have problems, relapse was ruled out, and what was there, and this was the spirometry, so there were obstruction, there was mild restriction, which were sequelae of tuberculosis, and the patient's problem to climb the stair, to do the normal work, etc., after having been cured. Next. So the document, those who are interested have in the slide the reference to look at. came out in 2016 with a series of, let's say, potential recommendations or suggestions that was to make a description of the situation of the patients at the end, particularly if the patients had problems, making some evaluations, including spirometry, including the LCO, the evaluation of the cases, the 6 minutes walking test, and the radiological evaluation and the quality of life evaluation, and also the idea that whenever rehabilitation is necessary or is undertaken, it should be evaluated also with a pre-post evaluation of the test. So the interesting of this is that in all these following documents, basically done by different people and totally independently, the same series of recommendations appeared, which might indirectly suggest, Ernesto will say that this is not scientific evidence, but there will be some sense if different groups at the same time saying the same things, right? So let's see a little summary of what is going to happen. So there is evidence, not super evidence, but sufficient to say that there is a decline of pulmonary function following TB disease in a certain proportion of patients. I will show also evidence in children in a recent paper. This can hamper the capacity of the patients to make exercise and also hamper the quality of life, not in all, in some. The prevalence of problems, let's say, in the literature ranges between 13% and 68% among new cases, and much more, and alarmingly more, from 75 to 96% in MDR TB cases. Why this? Because particularly in the past, in the era preceding rapid tests, etc., a certain number of patients come to MDR following different cycles of therapy, eventually having initially not correct or not effective regimens because the DST was pending, or patients who had, lost to follow-up, restart, etc. And during this time, the lung repair mechanisms with, fibrosis, etc., can contribute, could have contributed in generating difficulties in the oxygen exchange, etc. The mortality rates have been shown to be up to 3 times higher than that of the general population. And with focus on rehabilitation, which I repeat is not always considered by the previous documents, there are initial evidence that this may be effective, and of course, research is necessary to confirm this further. And then some evidence, I go rapidly from our own group, let's say, evidence that rehabilitation is effective in improving spirometry, improving walking distance on a sample of Italian patients, and evidence of obstructive and obstructive problems in a cohort of patients as described by Brian Howard. Next slide. Let's say, kind of evaluation which may be done, and the relevance of pulmonary rehabilitation, which is also summarized in this article again by Dina Viska, and a specific, let's say, experience from the reference center in Mexico, Marcela Munoz Torrico, focused on MDR TB patients in Mexico, which have a functional damage which is pretty important. 74% had persistent respiratory symptoms at the end of treatment, and 66% had functional impairment at the end. Next. Then I want also to present this viewpoint, which has been recently published, say since 2020 in reality, in the International Journal of Tuberculosis and Lung Diseases, which is the result of the first kind of international symposium, which was organized together with the Union Conference. And it is the first meeting which was dedicated to the post-TB issue with different experts, which came, as we will see, to kind of some standardization, at least, of definitions and let's say main concepts to be taken into consideration. Kind of standardization step to try to speak the same language. From the evidence point of view, as we had different cohorts, then we try to put the data together and recently published this paper, which shows different, let's say, results or characteristics in different kind of patients. For example, the Mexican cohort has more normal patterns. Italy had more mixed patterns. The Brazilians had more obstructive patterns. And interestingly, in the Brazilian cohort, they were able to follow the patients up and monitor in a subset of these patients and monitor the deterioration over time of the spirometry values, which is one of the pieces of evidence showing that this is going to happen. Pieces that will help to grow more evidence. So a point of a reflection in this next slide here on post-COVID, we have still a lot of question marks, and we know still relatively late on COVID-19 and its consequences. And we know that the TB-COVID relationship is still under discussion. We have a large study presently undergoing peer review under the ERJ, European Society Journal, resulting from a collaborative work with WHO and the Global Tuberculosis Network, which is showing that the patients with the double infection have higher mortality and higher morbidity. Hopefully, this will be accepted. Well, let's cross fingers, and will be available for circulation. So it's an issue to keep into account. Again, from the COVID-19 sign, there is evidence that rehabilitation works, and of course helps in improving quality of life. So this is because the two conditions have several similarities. Next slide. This is more let's say physiopathological curiosity. It is possible to utilize the assessment of the role, the assessment of alveolar to arterial oxygen, the so-called AADO2 gradient and PF, as a tool to monitor lung damage. This is just evidence that this is a parameter which might help to evaluate the blood gases exchange, and this can be used for post-COVID and also for post-TB. Next. Clearly, the issue is that many patients have several patients have a cumulative effect of respective sequelae, and therefore it's important to see how to approach at the end of the process when the patients are cured for TB and there is no more evidence of COVID eventually, to let's say to make a point and see which problems are still remaining and what can be done to help these patients to improve their quality of life, because these problems can be really severe important. And there is a document which will appear in the summer in the again in the Agri Journal on the clinical stance of post-COVID, which we invite you to eventually follow. This will be open access, so it will be possible for all to download and look at it. So the Stellenbosch Symposium, next slide, was basically at the time an advocacy importance, but also importance to set definitions and to achieve consensus. Trying to develop, this was the ambition, a toolkit for future post-TB lung disease measurement. And next slide. As we see here, we don't go into the details, but where there is the red bar, we see that we can measure different things. So an entry point is a self-reported questionnaire with symptoms, and then going to clinical measures, measurements, lung function, radiology, quality of life, etc., etc. Next slide. And this can further go on, look into lung complications and discussing issues like pathogenesis and what the sequel project is doing. And clearly, this is a very important idea, and it's part of the process to generate evidence and create awareness and stimulating new studies to be undertaken. However, not much is again discussed in terms of rehabilitation, and then we are there just to remind that this should be the logical consequences of whatever we found in that sense. Next. Then the measurement. So the effort that the Lancet Global Health paper made to measure. This is the famous paper. Clearly, we have a large amount of TB survivors, and it has been calculated that out of 122 million dailies due to incident TB in 2019, data that were used for the analysis, 58 million were attributed to post-TB sequelae, about half, 47%. But we will see that in all ages, in young ages, this the post-TB will exceed the one met during disease, because the younger the patient is, more years of life are expected, and therefore the qualities will be respectively higher than if you consider an older population. And we see here the paper takes into account 3 parameters: the years of life lived, the years lived with disability, and the famous dailies, disability adjusted life years. And we see the distribution by age of the red bars, and we see that even let's say in young age groups we have let's say the majority of the dailies. In this sense, the dailies are the most important. This is the parameter which is considered the most important. We see here that the area, this is the story of a single patient, right? And the green area is higher. That this is the post-TB. The green area is larger than the azure area. So the azure area is the one related to post-TB, and the other one is the area related to TB during disability. So we see that in these patients, more or less, they are half-half. But in young people, the post-TB are larger than these areas. All ages are affected, but as we have seen in young age groups, of course, we have higher dailies because of longer life expectancy. Next slide is a summary of a new clinical document by the Union, which is this one, published in 2023, Post-TB Health and Wellbeing. It's a clinical statement written by, let's say, by the same large group, which was, let's say, coordinating the Stellenbosch symposium. All this is because we have 155 million TB survivors, and the focus is not only on post-TB lung disease, but also on other disabilities, as let's say also Ernesto has mentioned before, including neurological, cardiovascular, and the with special focus also on children and adolescents. Again, rehabilitation is not discussed much. And we see here there are nice graphs, and here it covers the different dimensions: stigma, quality of life, the psychological distress, the economic consequences, etc., etc. Disturbances in sleep. Next slide. And the document also goes on in trying to propose a severity classification into mild, moderate, and severe. We define severe post-TB lung disease when we have significant and debilitating symptoms that reduce the quality of life and affect the ability to carry out daily tasks, when we have abnormalities in lung function, when we have also abnormalities in chest X-ray, and we have a series of conditions, of course, which might, let's say, contribute to future, even severe or, let's say, even life-threatening conditions, and might also favor the, let's say, aspergillosis and other chronic fungal infections or NTM, which might eventually also increase further the risk of mortality or anyway the level of disability. Next. Clearly, the document goes in defining which compartment is more affected. So what is the airway kind of damage and how to measure it with the functional evaluation, the parenchyma, damage with cavitation and the fibrotic, etc., including the aspergillus-related lung disease and the pleural and pulmonary vascular issues, which have here a kind of link with the cardiology and then the need of using Doppler, echocardiography, etc., to measure and evaluate the situation. Sophisticated kind of approach to an issue which is more common than was thought previously. And we see here examples of problems. The document emphasizes the so-called TOPD, which is TB-related obstructive pulmonary disease, and we see example of it, destroyed left lung, terrible. We see focal bronchiectasis, we see cavities, etc., and pulmonary hypertension in the lower right. And so it's really a huge planet that needs to be further explored to come to some potential ways of managing. The document then proposes that the usual, because documents are all structured in the same way, let's say steps of assessing, managing, and following the patients up. Next. So which patients? Those who are symptomatic, who have exacerbations, who have worsening and increased frequency or have new symptoms, who have no response to usual treatment, and they have impaired quality of life. The assessment includes not only clinical, of course, functional imaging, microbiology, comorbidities, but also a necessary component with counseling and education, with a management plan and a series of activities which are related to rehab and to optimization of treatment, the medical treatment, smoking cessation, and also a new chapter which is not being considered much, which are vaccinations. So there is a paper pre-accepted in pulmonology, which is a review we have done on the evidence on the need for vaccination in post-TB lung disease. A chapter was not considered in previous documents much, and which the Brazilian guidelines are already captured into the Brazilian document for, let's say, management of post-TB lung disease. And then the idea is now to add to the clinical standards a little addendum chapter on the role of vaccinations. Next. There are conditions which are, let's say, potential comorbidities or conditions for differential diagnosis, and among them aspergillosis, NTM, which is difficult planet to navigate with, other bacteria which are colonizing, etc. And then we have all the other potential diseases which mimic or can be associated with. So this is a planet for clinical specialistic investigation of some of these more severe patients. Next slide. This is specifically end treatment assessment in children and adolescents. And the documents see, okay, those are the tests. Clearly includes radiology, includes spirometry, includes minus walking tests. It's include a quality of life question, and when we have a severe example, and this is recommended to be done. Clearly, in case the problem is not severe, then it's enough to give a look to the clinical picture and exclude there are consequences. Next slide. This is the paper was mentioned by Marcela Muistorico, which the details on functional deterioration MDR. It's interesting for those who want to see in this cohort what happened to the severe MDR cohort. Next. This is evidence in children and evidence. This is going to appear soon in it's coordinated by in the Greek journal, and we see how in the paper, let's say the children with TB have we continue slide lower FEV1, and this is upper left, and in the lower right, they have the same problem. So it's clear to FEV1, to FEV1, and to FEVC. The idea is to be able to detect the patients who have a severe impairment and try to see what is possible to do in terms of follow-up and potentially rehabilitation. Let's say this is also a reading which we can suggest. It's a kind of summary of evidence on post-TB lung disease, which can be helped, recently published, to summarize a little bit what's going on for post-TB and post-COVID. Nice review by Emanuele Pontali. Next. Just going to conclusions of this first bunch of documents. Clearly, there is increasing attention on post-TB lung disease. We have seen let's say the results of the first review was published in the Journal Brasileiro de Pneumologia in 2016. There is growing evidence. We have seen the contribution of the Stellenbosch Union Initiative, standardizing definition and standardizing the approach. The international standards will be discussed soon. And then there was the second Stellenbosch follow-up paper, which we have seen, which was the clinical standards. And then we have seen the importance of the rehabilitation, which sometimes emerges, sometimes does not. And for the patients who have a problem, it's also, I mean, it's like we diagnose infection is to treat it. When we diagnose post-TB lung disease, we have to do something, right? So what to do? And rehab is one of these interventions. We just using San Francesco's words is that we do whatever is possible, but we try to make the impossible possible. So that's the stage, as Ernesto has clearly shown. And we are really starting discussing to see what is feasible. And this couple of years ago was considered absolutely not feasible, but in reality, it's unfortunately advancing. So thank you for your attention on this. I interrupt that. Should I go on with the second, Alex?
Yes, Elmira. Mm-hmm.
Yes, Professor Migliori, you can continue with your slides.
Very good. So I think in another 15 minutes is fine?
Yes.
Okay, so let me screen, which is the one. Voila, this one. Do you see it?
Yes, we do.
Sorry, it has gone to the end, so let me go to the beginning. Voila. So this is just summarize the standards, right? And basically, we have seen before that the question is, we are not finished when we have cured a patient. We have reviewed some of the evidence, of course, not all. There are very many little pieces here and there which are interesting. We have seen the history. And now let's see how the idea of the standards was to cover the clinical aspects and give a clinical guidance, including a list of potential research priorities, right? And the idea is that this presentation is a guide for everyone to read the original article, which was published in the Union Journal in October 2021. It's free access. Next slide. And now a little summary. So we know TB is poverty, related disease. We know there are several conditions which HIV is marked, but whatever else, which hamper the host defense and make this exposure, infection, active disease, and consequences of the disease, which is possibly like this, sometimes more rapid or more, let's say, probabilistically possible. Next slide. Now, we know that the infection, this is the famous paper in the Clinical Microbiology Review 2018, which shows that we don't have latent TB infection and end disease, but we have a process which is, you know, incipient TB, subclinical TB, active TB, that sometimes they progress, sometimes they reverse, sometimes spontaneously. So it's a planet much more dynamic than a two-stage process. It's probably didactically a five-stage description, which is probably even more complicated. But let's say that after that, there is also the planet of the post-TB Lyme disease. That was the sense of putting this in the big picture. Next. And again, this is a summary of this model we published in Brief 2021. So we have infection, right? So we have incipient TB, we have subclinical TB with no signs or symptoms. We have subclinical TB with some unrecognized signs and symptoms, which is a little bit the potential focus of our attention because they can transmit, but we have difficulty to diagnose. We have the typical disease, signs and symptoms, and then we have post-TB Lyme disease, right? Which is responsible of half or even more young groups, young age groups of suffering, and we have seen the qualities before. Next. Again, in that, let's say, consecutio of infection, disease, etc., we have different elements. We can diagnose infection, we can diagnose disease, and we can also diagnose post-TB Lyme disease. So the issue is what we can do to understand better this and what we can do to rehabilitate when we have a problem. Oh, next. Fine. So we have seen this classic, let's say, algorithm, and then we have to say, okay, let's add the post-TB screening and management as an element to keep into account. Clearly, we are at the moment discussing possibilities, piloting, understanding, but what we have to keep in mind is, which is a possibility at a certain moment, if this is shown to work and to be important, and to, if you can do something to consider, let's say, a programmatic step to it, which would eventually include a lot of resources. So it's an issue that is for now for thinking, but that will come. Next slide. So the international standards are a series of documents. There are several that have been published, drug susceptible. We have the one on TB infection, on the dosing or management of TB drugs. There are several. The one in children just out, etc. And this was basically the first published, and was on post-TB Lyme disease, because we consider this a super important topic. Next. So we have, this is the document. I repeat, full access, anyone can access it. 6 standards evaluating, let's say, how to evaluate the patients, identify if there is any need for, rehabilitation, design and evaluate the rehabilitation, how to complement all this process with education and counseling. So far, 5 clinical standards, 1 is public health standard. Those are the sponsors who we need to acknowledge, because they made possible to have free access for the document. Fine. So how this was developed, I go quickly. So we had a group of experts down here, different expertise to have all aspects covered. The panel made a Delphi process. There was formulation of standards, and then several work on this and approved by consensus, a kind of classical methodological approach to the standards. Next. We said those are the 5 standards. We look at them and then we go a little bit more quick through the content. So the first standard is how to assess the patients, and let's say what to do to approach that. This is standard 2, so identifying the patient with post-TB lung disease for pulmonary rehabilitation. How to, standard 3, adapt the rehabilitation program for specific needs and in specific settings. This is a bit new. It is really something is not written elsewhere. Why for the point 1 and part 2, other documents are also touching it, but not from the rehab point of view. Then we have the standard 4 on the assessment of the effectiveness of pulmonary rehabilitation, because we need to have evidence. There is some little piece of evidence here and there, but not. How to organize education counseling. Then, let's say the standard 6 is the public health standard, highlighting the need to record any change in patient outcome, right? So this goes in parallel with the recommendations in the outcome, which is when possible, when patients are already in the radar after cure over time. Let's see whether we have this consolidated cure after 1 year, et cetera, et cetera. So the idea to see if there is any relapse, and there was kind of discussion, sometimes or discussion on this topic at the time that we should develop the let's say, refine the treatment outcomes. And clearly, this point is important. So if a patient during the observation has relapsed or dies, etc., it's important to, let's say, to put this into the register and being able to be measured and evaluated, right? And finally, we have the priorities for further research. Next. Okay, so standard 1 goes to all the series of elements we have already seen. So for patients who have a problem, through the clinical evaluation and history, evaluation via chest X-ray, function test, the 6 minutes walking test, which I remember is a poor test. So we just need to mark the distance and measure in 5 minutes, which is the distance the patients can do, eventually before or after rehabilitation. If possible, monitored by a saturimeter. This will be good, but not sophisticated at all. A symptom score and quality of health questionnaire. This is what has been recommended. And we see here all the details of what can be done, and on the right column, how this can be adapted in special settings and situations. So rehabilitation can be done in a very complicated manner. Investigations can be done in a very sophisticated manner. But they can be also done in a relatively simple manner with portable spirometer and just asking the patients to walk in the corridor for 5 minutes. Next. The second is, let's say, how to, let's say, evaluate the patient with sequelae for pulmonary rehabilitation. And this is a bit new because rehabilitation was not fully in the radar. We have much more evidence, as Ernesto said this morning, on COPD, basically, mainly COPD, bronchiectasis eventually, but COPD, which is a rich disease, a lot of resources around that, right? And many things are probably similar, but we don't have, in many cases, evidence on specifically on TB. And then we have here, let's say, how to organize the process, and say this is a guide to the clinical evaluation of the patients that, of course, we cannot do here in such a short time, but the document needs to be a little bit digested. But this is complete, and there was consensus, and always on the right column, there is the approach to adapt to special settings. So there is the ideal, and then the potential adaptations. Clearly, we have to look what is ideal, but we have to be realistic. Next. When rehabilitation is done, how to evaluate, which is if it is effective, etc. So, and the best way to do it is to, let's say, compare pre and post. This can be done. So this is how the work can be organized with aerobic and strengthen the upper and lower extremities, the inspiratory muscles, provide, let's say, ensure clearance, providing oxygen. So this is also the topic of the following presentation in practice from Latvia. And We have then also the important part on ventilation, on invasive, and the nutritional support. These patients have a high consumption of calories to breathe, so nutrition is important. And of course, the psychological support. We know that the patient-centered approach, etc., is the new vision all around the patients, and the psychological support should be extended also to the post-TB lung disease patients, of course. Next. How do we evaluate and which are the core valuable to use in the post versus the pre-PR for rehabilitation comparison? And also how to maintain the results, because you know, from COPD, there is evidence that you improve when you do rehabilitation, but if you don't maintain, you lose. You know, so you need 4 weeks to gain, like an athlete who is training, right? And then you need much less, 10 days to lose if you don't continue. So the rehabilitation should be followed by a maintenance program, which is making exercise, climbing the stairs, doing these kind of simple things to maintain or even further increase in a supervised manner, possibly the results achieved. Next. Here we have all the details on what can be done and how, etc. So I need you to read the full article. Standard 5 is on education counseling, and the idea here was to, let's say, propose, as in the next slide, a series of components which might allow also to go to some cross-cutting issues like infection control, smoking cessation, etc., quality of life, nutrition, optimal healthy lifestyle, etc., which at the end of the day are common messages that are given to patients. And that should be also reinforced motivation for this patient to continue their, I would say, PR pulmonary rehabilitation after the end of it, just as a maintenance.
Sure.
Next. We have also this table which shows what to do in terms of microbiological examination, clinical examination, imaging, 6 minutes walking test at different timing after assessment, etc. is eventually a useful guide to plan these activities, so you know where it is when you will pass through the document. Next, we see the blood gas analysis, GA, and how to monitor saturation of oxygen, tidal breathing, quality of life questionnaire, SCG, and other cardiological examination, again, in the flow of ideal examination that can be done. Not all are absolutely necessary, but potentially, when possible, of course, they are useful. And finally, we go to the standard 6 we have already discussed before. So notify any change of status, just to allow the register to contain information which, let's say, will in the future allow to understand which are the patients which have a higher risk of deteriorating, dying, improving, etc., and which interventions might help. In the next slide, we have a list of potential research priorities, which can eventually be merged with other similar lists existing in other documents. Several of these topics are, let's say, similar. And of course, we have included some elements on rehabilitation that is usually not very much yet considered. Next slide, we go to conclusion. So in perfectly 45 minutes, as promised. This document, the clinical standard, is a little bit pioneering definition on the approach, clinical approach to the patient with sequelae, following them during rehabilitation, providing counseling and education. Evidence in similar areas is initial, in others it's really or not even existing. So the document says sometimes this is derived from COPD, where situation is rather similar. We need evidence specifically for TB, etc. And we have also some indications for future research priorities. So I want to thank all the very many colleagues who participated into this, and we have representative of Stellenbosch, of TB sequel, etc., in this effort. It's really global, and I think useful. And I thank you for your attention, and I remain at your orders for the discussion. And thank you. Sorry, I was a bit long, but I had talks. Thank you.
Thank you so much, Professor Migliori, for this excellent overview and very useful references that I believe that that our participants will have a look into this articles, manuscripts, and clinical standards that you refer to in their routine practice. And now I'm very glad to introduce our third and last for this webinar presenter, Dr. Liga Kuksa, from the Volcha Collaborating Center for Research and Training in Management of MDR TB, who will share example of Latvia in actually implementation of pulmonary rehabilitation after TB cure. So, Dr. Kuksa, the floor is yours.
So thank you very much. Good afternoon for everyone, and thank you very much for introduction, and thank you for inviting me to talk in this webinar. And I'm really delighted to present together with such well-known experts. And also I take the opportunity of having a floor and change a bit the title of my presentation with putting a question mark at the end of the title. So, and I hope you will see that my opinion during this presentation. And regarding the pulmonary rehabilitation, and there is one of the latest definition of the pulmonary rehabilitation, but I would like to say that all who work in tuberculosis more than 20-30 years know that the exercise trainings or breathing exercise trainings were part of tuberculosis programs for many years, and I'm really happy that we now are talking about the pulmonary rehabilitation as a very stable part of TB programs, and I really very much looking forward to see also in my country put it in guidelines for tuberculosis. There I will show some two cases like basis of my presentation, and also explanation about the need of rehabilitation during the treatment and also after treatment. And those are two MDR TB patients, but I'm sure, and also the previous colleagues showed that we are talking about all people affected by tuberculosis, regardless of drug resistance or age or any other status and condition. So the first, my case is Ilse. She is 37-year-old. She was diagnosed in January this year, and we know that patient.
Liga, I'm sorry to stop you, but you don't have your presentation on. We only have Russian version right now.
Yeah, it was also for I saw the same for GB. I don't know.
No. You haven't launched your presentation in English. We only have the ones that Svetlana has launched.
Oh, that's sorry. Then I have to start from beginning. But then what is the problem? Who knows?
Just press share screen, and
I did this share, and now
you do. Now you share. Yeah.
That's strange, actually, but okay.
Yeah.
Can you see?
Yes, we can see the first slide, pulmonary rehabilitation.
Presentation. Now, next slide, please, with definition. I already went through this. And next is Ilse. Next slide, please. Ilse, 37-year-old. And we know that patient has mild mental retardation, and also during the treatment we recognize that the patient has also adjustment disorder with anxiety. And actually she was diagnosed in January, and what we can say that somehow we failed in this case, because the patient can say not in the healthy mental status, but also not the mental, fully mental disability. And those in the middle statuses are probably not very well assisted in, not very well good assistance in our country. And what was the result? That patient didn't recognize that she is ill. She lived with severe symptoms for several months. And finally, she found it in a hypermarket and were sent to emergency department and diagnosed with tuberculosis. And finally, you see that this is the X-ray, which is showing that for sure this patient has a very advanced disease, tuberculosis disease, multidrug-resistant tuberculosis. But for sure, we can say that there is unreversible lesions in the lungs. We never think that she ever will have fully healthy lungs. Nevertheless, patient started treatment. She is put it on a modified shorter treatment regimen. She is tolerating quite well, and also conversion happened after 1 month of the treatment. And actually, it really refers to the first presentation that we have patient with mental disease, which is one of the determinants for tuberculosis, but also we always have to think about the recurrence of disease, because these people also are at risk to later develop the problems and also recurrence of disease. So the second patient is 46-year-old. Again, we talk about the determinants because the patient is unemployed. He is smoker. Actually, I counted those are more than 38 pack years. Patient also use alcohol depending on the availability of finances because he is living on the mother's pension. And he was diagnosed late again in October with smear and culture positivity, rifampicin resistance, and started treatment. And after 2 months, converted. But if you look at the X-ray, again, there are huge lesions in the lungs with cavities in left upper lobe. And also patient has breathlessness, cough he has for more than 15 years. And for us as a program, always this question, how to reach this group of people who are heavy smokers and also alcohol users. And also, in addition, patient has several contacts with tuberculosis, known contacts and unknown just by nickname. We have no possibility to identify them. So, and those are 2 patients, and on basis of what I want to explain the experience. Actually, who is seeing the patients and who see the whole picture? And those are treating physicians, because there could be in a hospital, the physiotherapist could be a rehabilitation specialist, could be advanced techniques, but the main person who sees the patient and who sees the comorbidities, social problems, any kind of adherence problems, this is treating physician. And this person is who plans and also is responsible for the patient rehabilitation. And I'm not talking only about the physical rehabilitation, because meaning if we treat patient on the hospital, then transfer to outpatient, this is also part of kind of rehabilitation or returning the people to the normal, not normal, but healthy as possible life. And the rehabilitation usually is designed to, first of all, reduce the symptoms, depending on each patient. Like for Ilse was more breathlessness and endurance training. Then for the Yevgeny's more cough, and maybe more understand what actually the smoking brings to his lungs, and how to live with that in the future. Optimize functional status, and improve health-related quality of life. And both of them, you may see that are very affected with tuberculosis and other conditions as well. And pulmonary rehabilitation usually start with patient assessment, like in our everyday work. Also, we start with patient assessment. This is part of the pulmonary rehabilitation. And how it is happening in our hospital, the next step, and in many cases very soon, could be the next week of the treatment introduction, could be maybe depending on the patient condition. We think about the involvement of the physiotherapist in our treatment let's say activities. And usually I will say in next slide about the exercise therapy, but that's the main part. And actually I remember when I started as a residential doctor that rehabilitation doctor said to me that there is almost zero patients who can do at least very basic exercises. For example, bedridden patient can do quite many exercises laying in the bed and thinking about the muscle involvement, but that's not me who is drawing now. So yeah, about the exercise therapy. And the next is education of the patient, because we know that for any kind of exercises, any kind of rehabilitation, we need the adherence or compliance of the patients. And that's the education is the basis of the compliance, because the person has to understand what is happening, how it impacts their life, and how to proceed. And also, if it is needed, psychological support, because it impacts each other. And if needed, physical therapy. I'm not going to talk much about the physical therapy, because we still use physical therapy, but more for a sequel of extrapulmonary tuberculosis, like joint and bone tuberculosis, and also in case of adverse events like polyneuropathy. So, and my main forms of exercise therapy are breathing exercises, and you probably also you have the same experience, but the 98 or 9% of people are not familiar with breathing exercises, which is probably normal, but they also never heard about the impact of gas exchange and how it could help in many ways in their situation. Those are peripheral muscle trainings and also training of physical endurance in cases. And so back to the Ilse, to knowing the story before, also we understand that there is enlargement of right heart side, and we also detected pulmonary hypertension. By the way, patient also is malnourished, which was mentioned in previous presentation. She has 180 centimeters height with only 55 kilograms weight. And straight after the first 2 months of the treatment in the hospital, we were able to transfer patient to the local regional hospital from where she is coming, because you know this anxiety issues that usually are linked with the situation when people are taken out from their how to say common environment, and that makes more anxiety. They are anxious, and then we can't be sure that we can organize full treatment and expect for the improvement. And we were tend to send her back to the regional hospital, actually for the outpatient setting, but thanks to COVID, the rehabilitation structure is much more better than before COVID, and we were able to put on 2 weeks intensive pulmonary rehabilitation course in the regional hospital with the stress of social support as well, because we are pretty sure that that patient will follow all our recommendations, but with some specific assistance. And this patient is very compliant, but the problem is the mental status. That maybe next day, if there will be not a reminder or encouragement from somebody, that she will not be able to continue, or maybe not understand that she needs to continue. This is the and now currently she is sending all the time through the messenger the pictures of herself. She is on the outpatient treatment and receiving everyday treatment for multidrug-resistant tuberculosis. The second patient is also now in outpatient stage. And there was a bit different situation because he is quite reluctant to any kind of exercises. He doesn't believe that something could help. And this is again for us question for treating physicians with everyday follow up, not to put on the physiotherapist's shoulders that that they will follow and will do the exercise training or what is prescribed for the patient, but also you as or I as a treating physician follow every day, and also showing that the real benefit and real fruits of the exercise training. And also there you see the 6-minute walking test. And I think that we have to measure patient respiratory status, such patient respiratory status with spirography and 6-minute walking test as soon as it is possible, and also after the treatment, as well as it is written in standards. And due to the compliance problems, and also we were not able to organize video supported treatment for the patient, firstly we discharged to regional hospital. Good that there is a physiotherapist, they will follow exercise training, but very soon the family members activated, and that was actually a surprise for us, and they organized smartphone for the patient, and now he is on the video supported treatment. But also we still struggling how to follow up with exercises for this patient, and also long-acting beta agonists were prescribed for this patient. And again, the very how to say big question is how to ensure the compliance to all prescribed treatment besides the TB drugs. And maybe this is also one of the thing for us all as experts, and also for WHO, to think about how to ensure the adherence to exercises or to rehabilitation, because it's not the one day happening or 2 weeks happening or during the treatment happening. It should be followed, for example, for these 2 patients all their life, more or less, maybe with not so huge intensity, but anyway. And very often there is a question that we have a lot of responsibilities, and there is no time to do assessment of the patient, and this we are just adding to TB programs, and we were overwhelmed. But this is study coming from the China, and also we had reference in this month's Union Journal to this article that it's not very long time to assess patient functional abilities or disabilities. And it was measured that 6-minute walking test took just over 20 minutes. But from this study was seen that nearly half of the patients had ongoing symptoms. That's the end of the treatment. 20 of them were unable to walk 400 meters in 6 minutes. My patient walked 68% of the calculated distance for his age. 20 had associated diabetes mellitus, and also 10% were current smokers. In Latvia, I believe would be, I would say 70 probably percent are current smokers. And I really much looking forward that we have a lot to do. Also in Latvia, we have how to say, very basic things we do, but still to improve, we have a lot. And I really much believe that there is big space for pulmonary rehabilitation. And like previous speaker said, it seems impossible, but a lot of things are possible if we are tended to think about them. We make the real plans and do them and follow them. Thank you very much, and I hope that there were not so many. I've not used so much time. Thank you very much.
Thank you so much, Liga, for very interesting examples, and I really share your hopes that soon we will see that pulmonary rehabilitation is the standard of care, not only after TB is cured, but during the TB treatment. Thank you so much. Unfortunately, we're out of time. We try to answer almost all questions in the chat, but there is still one question that came to Liga when she during her presentation. Maybe Liga, you can answer to this question, and we will finalize the webinar. And the question is: does pulmonary rehabilitation exercise is the pulmonary rehabilitation exercise and that we're provided in on outpatient basis, and if there are any staff units provided for that, and in what are the structural divisions where the pulmonary rehabilitation is provided in your example?
So yeah, the pulmonary rehabilitation is possible in outpatient setting. It's not a responsibility of the TB program, like also from the National Health Service. But if patient is assessed by the rehabilitation doctor and he prescribes rehabilitation, that it is possible to do in outpatient setting. The only problem is again money. No, not more than 10 days usually. If the patient has extra pulmonary tuberculosis, then is with bone and joint involvement, then is more possible to have larger program. But for pulmonary, like let's say fully pulmonary rehabilitation, we still have quite a lot of limitation, and also unfortunately feasibility in regions. It's not feasible more than physiotherapist guidances, but not like full rehabilitation program. The only exception are a bit bigger cities, like I showed the Ilses example. This is a city which is the third or fourth by the size after the Riga, and then in some big municipalities there are some more possibilities, but it's still quite neglected for the TB patients.
Thank you so much, Liga. That's exactly where the what mentioned Ernesto, WHO policy and generation of evidence may help to advocate for more budgets for pulmonary rehabilitation. Thank you so much for all this, our great speakers and our auditory, for this very interesting, insightful webinar, and your participation, and all the questions and provided answers. I would like to know that it was really for the first time when we've been talking about TB-related disability, but I hope that as soon as Ernesto and the team will have a policy document, we will come back to this topic. Thank you so much, and have a great summer ahead. See you soon during the next webinar.
Thank you, everyone.
Thank you.
Bye.
Thank you. All the best. Bye.
Bye.